Welcome everybody to Pathway Genomics webinar on hereditary breast cancer, genes, associated syndromes, and testing options. My name is Adrian Vilalta. I am the Senior Director of Genetics here at Pathway. We come to you here today from beautiful San Diego, California. Today's discussion will be on breast cancer, ovarian cancer, with emphasis on the hereditary component of the disease. We'll discuss BRCA1 and BRCA2, which are the two genes that confer most of the risk for hereditary breast ovarian cancer syndrome. We'll discuss the distribution of BRCA1 and BRCA2 mutations and ethnicity, with some emphasis on Ashkenazi Jewish ancestry. Very, very exciting for us. We will talk about the breast high-risk panel that contains PALB2 gene. We'll touch on the clinical guidelines associated with this panel. We'll discuss this. And we will conclude with a brief discussion of the sequencing technology and the variant classification process that we follow here at Pathway Genomics. So death from cancer amongst Hispanic women, and is the second cause of death from cancer amongst all other ethnic groups in the U.S. Numbers from the Centers of Disease Control and Prevention for 2010 indicate that over 200,000 women and over 2,000 men in the U.S. were diagnosed with breast cancer. The same year, over 40,000 women and 400 men in the U.S. died from breast cancer. These are simple numbers that convey the magnitude of the problem. It is estimated that 1 in 8 women will be affected by breast cancer in their lifetime. That translates into about 12.3% of the overall population will develop the disease over the lifetime. For ovarian cancer, it is estimated that 1 in 71 women will be affected by the disease over the lifetime. Now, studies over the last 30 or 40 years have indicated that a small number of genes are responsible for most of the hereditary risk for breast and ovarian cancer. In the early 90s, BRCA1 and BRCA2 were identified as the two predominant genes harboring these highly penetrant mutations. BRCA1 was first described by Mary Claire King at the time at UC Berkeley and current winner of Lasker Award. BRCA2 was described shortly thereafter by teams led by Dr. Stratton and Worcester in the UK. Now, mutations in either one of these genes results in an up to 85% lifetime risk of breast and ovarian cancer in those high-risk families. At the same time, those families defined by multiple cases of breast and ovarian cancer can be attributed to mutations in BRCA1 and BRCA2. Now, hereditary breast and ovarian cancer syndrome is an autosomal dominant disorder that can be traced back to mutations in BRCA1 and BRCA2. Risk conferred by those mutations is summarized in the graph shown on the left side of the screen. As indicated, carriers of BRCA1 mutations have an increased risk over the general population. That risk is approximately 60% over the lifetime of the woman. In the case of BRCA1 carriers, the risk of ovarian cancer over the lifetime of the individual is close to 40%. For BRCA2 mutation carriers, the risk of breast cancer is approximately 40%, while for the same people, the risk of ovarian cancer is anywhere between 10 and 20%. Clearly, these mutations confer a highly increased risk compared to the overall population. Now, mutations in BRCA1 and BRCA2 are also associated with other types of cancer that include fallopian tube, breast cancer, as well as potentially some skin cancers. Now, mutations in BRCA1 and 2 are highly penetrant. What this means is that the probability of developing the disease when the mutation is present is very, very high. This fact is demonstrated by the pedigrees shown on this slide. The family shown on the left is a family that is affected by BRCA1 mutations. Just for the non-initiated and non-experts, the circles represent females, the squares represent males. The X stands for diagnosis, the age of diagnosis. And each row in these pedigrees indicates a generation. So in the BRCA1 example, we have a female that was diagnosed with ovarian cancer at the age of 49. Two of her daughters were diagnosed with cancer as well, with breast in one case and ovarian in the other, at the ages of 42 and 53 respectively. The granddaughter of the original woman here was diagnosed with breast cancer at the age of 38. So several things become apparent when you look at this pedigree. The first one is that the probability of developing the disease once this mutation is passed on is very, very high. In this case, we have 2 out of 4 women developing cancer. The other one that is also very striking is the age of onset, as it's called. So in the first example here, we have the grandmother in this family developing ovarian cancer at an early age of 49. 2 daughters developing cancers, one breast at 42, the other ovarian at 53, which are considered early onset. And clearly for the granddaughter developing breast cancer at the age of 38. So clearly highly penetrant and also early onset. In the case of the family on the right side, we have a BRCA2 example where the first individual, the individual in the first generation is actually a male who was diagnosed with prostate cancer at the age of 55. 2 of his daughters were diagnosed with cancer as well, one with breast at the age of 45 and pancreatic at 55, and another one with ovarian cancer at the age of 58. Now, the grandson has been diagnosed with male breast cancer at the age of 52. So in the BRCA2 example, it is also very clear that penetrance is high. Age of onset is also early onset. And also we see a different distribution of types of cancers. In this example, we have prostate cancer, pancreatic cancer, male breast cancer. So clearly when one looks at pedigrees, we must be mindful of not looking only at breast cancer, ovarian, but also the full spectrum of potentially BRCA-associated cancers. Now, BRCA1 and BRCA2 mutations are not distributed equally across ethnic groups. This is indicated and exemplified by the table shown on this slide. These are numbers coming from breast cancer survivors in the United States. Here we indicate that women of Ashkenazi Jewish background have a proportion of BRCA1 mutations ranging from 8.3 to 10.2, and BRCA2 mutations 1.1%. The second one group that is clearly affected by BRCA1 mutations is Hispanic women with 3.5. The other numbers are clearly indicated as well. So BRCA1 mutations, although they can affect women of all ethnic groups, tend to be more highly represented in some groups over others. Now, it is estimated that damaging BRCA1 mutations and BRCA2 mutations are 1 in 400 in the general population in the United States. At the same time, BRCA1 and 2 mutations are 1 in 40 in Ashkenazi Jews. And this is just to emphasize it's true for women and men. To help patients in this type who might be interested in being tested for mutations in BRCA1 and BRCA2, Pathogenomics offers the so-called BRCA True test that looks at the whole coding region of BRCA1 and BRCA2, also including 20 base pairs on either side on the intronic regions. Now, a little bit more detail on founder mutations in Ashkenazi Jews. It is estimated that approximately 2.5% of all people of Ashkenazi Jewish, that is Central Eastern European background, carry one of three so-called founder mutations in BRCA1 and BRCA2. These mutations are 185-del-G and 5382 in C in BRCA1 and 6174-del-T in BRCA2. A little bit more on the statistics around this. So it is seen that in high-risk Ashkenazi Jewish breast cancer families, a BRCA mutation of this type, of the founder mutations, is detected in 44% of the individuals. Also, if these families include members affected by ovarian cancer, then 73% of the families segregated a founder BRCA mutation. Now, to help patients interested in testing for any of these founders, Pathway Genomics offers the BRCA True Ashkenazi Jewish 3-site panel that looks exclusively at these three mutations. Now, although we just discussed founder mutations in people of Ashkenazi Jewish ancestry, founder mutations can be found in other ethnic groups and affect individuals from countries around the world. For example, there are some well-known BRCA1 mutations in Mexico and in other Hispanics. 185-del-G is highly represented, as is deletion of exons 9 to 12. Women in Denmark, Japan, and Norway have also have a higher prevalence of founder mutations, as indicated in the slide. Now, for people interested in testing any specific mutation, either one of these or any other in BRCA1, BRCA2, or any of the other panels that Pathway offers, we have the BRCA True single-site option that can detect any of these mutations individually. So then, what about other hereditary breast cancer-related genes? To have that discussion, it's useful to look at the relationship between the estimated risk and the frequency of variants. It's been observed that there is an inverse relationship between the penetrance of the mutation and the genes and the frequency of the variants. When one looks at this kind of analysis, it's clear that there are basically three types of genes associated with breast cancer risk. The genes in the red zone are those genes that in which the mutations are highly penetrant. That is, mutations in those genes will have a high impact on the risk for developing the disease. The yellow area here represents genes that are less penetrant, somewhat moderate impact on the increased risk for breast cancer. At the same time, mutations in those genes tend to be more frequent. Finally, we have the green zone, in which mutations have much lower impact on the increased risk for breast cancer, and at the same time, the frequency of the variants is much higher. When you look at what genes are in what zones, it's not surprising to find BRCA1 and BRCA2 in the red zone, but also some other genes like TP53, CDH1, PTEN, STK11, and now PALB2. Other genes in the different zones are indicated in the slide. Now, Pathway Genomics developed a highly innovative test that captures mutations in the top 7 high-risk genes and put it together as a panel. This is called the Breast True High-Risk Panel. Now, there are very clear guidelines in terms of clinical management for many of these genes for BRCA1 and 2, and it's clear that the risk is well captured. Breast cancer is about 41 to 90% according to NCCN, ovarian 8 to 62. Now, some of the other genes, right? Let's talk about CDH1. It's well characterized as the main driver for hereditary diffuse gastric cancer syndrome, for which there is a clear increase in diffuse gastric cancer as indicated. In addition, there is a 39 to 52% risk of developing lobular breast cancer. PTEN is associated with Cowden syndrome. That confers an increased risk for breast cancer of about 85%. STK11 is associated with a syndrome called Post-Jaggers that confers a 44 to 50% increase in breast cancer and about an 18 to 21% in ovarian cancer. P53 is associated with leaf-from-any, with mutations in P53 result in an increase of 95% of several types of cancer. Now, to get more details as to the clinical management for people with mutations in these genes, I refer you to the NCCN document indicated on the slide. Now, important to mention, the NCCN is currently revising and reviewing the discussion in this document, most likely because a discussion needs to be included around the risk conferred by PALB2 in addition to other things. Interesting also in this newest version of the guideline from NCCN, it's clear that they support the use of gene panels in terms of evaluation, for the evaluation of the overall risk for cancer in patients. Now a little bit more on PALB2. PALB2 is a partner and localizer of BRCA2, and that's where the PALB2 acronym comes from. It's been known for a while that biallelic mutations are associated with Fanconi anemia in this gene. Monoallelic mutations are associated with breast and pancreatic cancer. Now, groundbreaking report from August 2014 fully established PALB2 as a key player in increasing breast cancer risk. The numbers reported in this paper indicate that there is a risk of anywhere from 33 to 58% of developing breast cancer over a lifetime. So clearly PALB2 now is on par with BRCA1 and BRCA2 in terms of the breast cancer risk. Now BRCA1, BRCA2, and the rest of the high-risk panel genes confer risk for many other genes, as also indicated a little bit on the NCCN guidelines. This slide summarizes some of the other risk associated with mutations in those genes. Clearly, for genes like P53 and the leaf-from-any syndrome associated gene, we have a risk for breast cancer. We have sarcomas, leukemias, brain tumors, and such. For P10, breast, thyroid, endometrial, and kidney. STK11, again, breast and ovarian, cervical, uterine, testicular, and so on, as indicated in the slide. CDH1, we already mentioned its connection with increased risk for hereditary diffuse gastric cancer, as well as lobular breast cancer. PALB2, breast, pancreatic, ovarian. These associated lifetime risks incorporate risk for all of these indicated neoplasms. Now, this is an important point that we need to make. So when one evaluates pedigrees of patients at high risk, if one wants to consider testing for any of these genes, one must consider other genes in the family, not only breast or ovarian, in order to get the best indication of risk. Now, this is an important question, right? So who should be tested? Clearly, this is a conversation that must be had with a medical professional. But what we can say is that Pathway Genomics has developed the BRCA2, the BREST2, BRCA2 Ashkenazi Jewish, and so on tests, thinking about patients with a strong history of early onset breast or ovarian cancer, or individuals that have a strong family history of breast ovarian cancer. I should expand here to include patients that also have some of the other high-risk gene-associated cancers in their family tree. Now, to summarize as a bullet point, individuals that have been diagnosed with early onset breast cancer, especially if it's diagnosed under the age of 50, or that have had bilateral or multiple breast cancers, diagnosed with both breast and ovarian cancer, family history of breast and ovarian cancer, or 2 or more BRCA1, BRCA2 related cancers in a single family member, or if there's a family member with male breast cancer. And in addition, anybody who is of Ashkenazi Jewish ethnic background should think about discussing genetic testing with a medical professional. Now, this is a summary slide that discusses the genetic testing options from Pathway Genomics. The first one that we want to talk about is the BRCA2 Ashkenazi Jewish 3 site. As discussed previously, in this test we look at 3 specific mutations, founder mutations found in Ashkenazi Jewish individuals. The second testing option is BRCA2, that looks at the complete coding region in addition to some intronic regions for BRCA1 and BRCA2. We have BRCA2, that is our newest introduced panel that includes the 7 high-risk genes, BRCA1, 2, CDH1, PALB2, P10, STK11, and P53. And then also we have interesting reflex options that might be of interest to clinicians. We have the BRCA2 with reflex to BRCA2, in which we look for mutations in BRCA1 and BRCA2. If none are found and or only a VOS is found, then we automatically reflex to testing the rest of the high-risk genes. In the BRCA2 Ashkenazi Jewish 3 site, with reflex to BRCA2, what we do is we look for any of the 3 Ashkenazi Jewish founder mutations. If none of those are found, then we reflex automatically to sequencing BRCA1 and BRCA2. In addition, as we mentioned, we can test for any single mutation in any of these genes. Now, if you want more information about any of these tests, I would encourage you to reach out to client services here at Pathway using the number on your screen or the email. Or if you want more information around any of these tests, please visit us at the website shown on your screen. Now, a brief discussion on sequencing technology and variant classification. Here at Pathway Genomics, we use cutting-edge technology for DNA sequencing and large rearrangement detection. The first thing we do when we receive a sample, we enter it in our system. We proceed now to isolating the DNA using highly advanced robotic systems. At this point, the workflow splits. We take some of this DNA and use next generation sequencing to look for any kind of variants. Now, importantly, if we don't have enough coverage in regions of any of these genes, and we define this by regions that have depth of less than 25x, we use Sanger chemistry to backfill. In addition, if we do detect a variant, at this stage, we confirm the presence of the variant by using Sanger chemistry. Now, the second fork of the workflow indicates that we look for deletions and duplications by using ACGH, which is a highly advanced technique to look for large rearrangements. At the end, we do some powerful bioinformatics to integrate all of this information and compare against the reference genome. If a variant is found, that is, if there is a difference between our patient's DNA and the reference genome, then we have a variant that needs classification. Now, this is a very robust and sensitive process, as indicated by the numbers on your screen. Now, it is known that genomic DNA amongst individuals is not identical. There are actually many differences between individuals. Now, most of those differences have no impact whatsoever. Some other variants are what help us make us unique, right? But they have no negative clinical consequences. Only a few of those variations actually will have deleterious effects, but identification and classifications of those requires thorough scientific analysis. Here at Pathway Genomics, we have a team of of geneticists, molecular biologists, cancer scientists, and so on with PhD level training that are charged with classification. The process is outlined in the following way. Once a variant is identified in the lab, one of the members of the team looks at all the scientific information available, either published literature, frequency information, bioinformatic data, and such, and provides a classification and a risk estimate. Those findings are then are reviewed by a second scientist. Once these two individuals reach agreement, then they reach out to the director of the group that is then charged with reviewing all this information. And if everything is fine, then and upon approval, we will have a draft classification and risk estimate for that specific variant. Now, after that, there is a clinical review committee composed by MDs, genetic counselors, and PhD level scientists that look at the overall package, the overall report. So the variant is then reviewed in context with any other variants found in that specific patient. In addition, if we have any information about personal and family history will be taken into account. That will result in a final classification and risk estimates in addition to patient-specific comments and recommendations. Here at Pathway Genomics, we use a 5-tier system to classify our variants based on ACMG guidelines. We bin our variants from pathogenic to benign. Pathogenics are those variants that have established clinical significance with a demonstrated increased risk for the disease. These are also called mutations. Likely pathogenic are those variants for which the data is preliminary but still suggestive of an association with disease. Uncertain pathogenicity, or VOSs, have either no supporting data or the data are conflicting, and therefore no clinical significance can be established. The first three classifications, that is pathogenic, likely pathogenic, and VOSs, are reported in our tests. Now, likely benign and benigns are not reported. However, we still classify them and in the following manner. So benigns are those for there is a strong evidence of a lack of association with an increase in disease. Basically, they are neutral from the clinical perspective. Likely benign are those variants that have some evidence but is not fully established. However, it's clear that those variants have little chance of having an association with disease. Very importantly, we want to stay current with the classification of each one of those variants. So every 6 months or earlier, if we have reason to do so based on new data, we take a look at each one of those variants and reanalyze it. So we look at variant frequency, we look at any familial studies data that we may have, new published data, new functional data, and so on. If after this analysis we decide that the reclassification is not warranted, we document the decision and we leave the variant with no changes till the next round of reclassifications. Now, if the decision, on the other hand, is to reclassify, we reach out to the physician using any means that this physician indicates to us. And at the same time, we provide a notice on our website about the reclassification of the specific variant. In summary, in terms of the classification, we follow very strict scientific criteria consistent with ACMG guidelines. The classification is based primarily on clinical evidence and consensus expert opinion. We do not use bioinformatics primarily for classification. Neither we use in vitro assays or animal models. Now we do periodic reclassification analysis, looking at all new data, in-house family and population data, and so on. And these variants are then classified by a cross-functional team of genetic scientists, molecular biologists, and such with PhD level training. Well, this concludes our webinar today. I would encourage you to provide feedback by following the link shown on the screen. You can get more information about any of these tests in addition to all the other tests provided by Pathway Genomics by visiting our website. And if you have any questions about this presentation, you are welcome to send them by email to the address shown on the screen, or by introducing your question in the chat box in the WebEx, using the WebEx tool. With this, I thank you on behalf of the whole team here at Pathway Genomics. Thank you for your time and your attention. Now we can spend some time, and I'll take any of the questions that have come off through the WebEx tool.